I'm Don Rice. I work at SSTAR Family Health Center over in Fall River. I'm relatively new to the area, so the welcome here has been amazing. And I want to say thank you for having me here. It's a pleasure to talk with you guys and share what I can about PrEP and what's coming on the pipeline for treating HIV. Looks like my calibration's off, so I'm going to bring it in a little bit. I'm supposed to talk about PrEP, but what I'd really like to talk about is ending the HIV epidemic. And PrEP is one of the tools, and I'm going to explain why it's probably one of the critical tools, but it's not the only tool. Every pandemic, every epidemic we see reveals some maladaptation or rift in a society, some form of a medical desert where Part A is not getting into Slot B. We're not taking care of our expectant mothers. We're not taking care of reproductive rights. We're not taking care of immigrants. We're not taking care of folks who engage in injection drug practices. We're stigmatizing our folks that have sex with other men. Each one of those gaps is where an epidemic can be born or where it can thrive. And until we close those gaps, we will have disease, we will have epidemics, we will have pandemics. HIV is not just about treatment. It's about dealing with mass incarceration. It's about dealing with people before they get addicted to drugs. It's about using every single step in the spectrum of treatment for harm reduction and substance use treatments that we have available. It's about decarceration. It's about reproductive rights. We can't just start here and take a PrEP pill and get rid of this. It will help. PrEP right now, and that's going to change, is a once-a-day treatment before you get exposed to HIV. You take a pill, take it for a few weeks. It takes a week to a month to kick in. That gives you a protection against getting exposed, getting infected during exposure to HIV. It's excellent protection. We're talking 100% for the data we have for sexual transmission. I'm going to tell you that 80% for injection drug use is BS. That was done with just tenofovir. It was done with half of the current recommended PrEP. And they did not check for adherence. They did not check drug levels. That was just weak data. We know it's at least 80%. It's way better than 80%. In the MSM and heterosexual world, for people that take PrEP, it's not just safe and effective, it's durable. You could take this thing 4 days a week and still get 70% protection. I could do that. And I'm not super good about taking care of myself. And it's available. Everybody can prescribe it. It's not like Suboxone that's restricted to just like 5 people. Anybody can prescribe PrEP. They can prescribe other stuff. It's around. So why is this so important for ending the epidemic? I can help one person, which is important. That builds trust. That gives us a stake in the community. But we've all learned about reproductive numbers with COVID. A reproductive number less than 1 means we're going the right way. Once someone gets infected with HIV, in the first month, they have a higher viral load than they'll have in the entire rest of their life, whether they're on treatment or not. Their viral load will never get higher, except occasionally, than the first month when they're infected. So that's where the majority of our transmissions happen. We got to go from 0 to 60 in 2 weeks. We can't do it. So I can't prevent transmission from one person to another only with U equals U. We actually have to block on the receiving end because of that first month. So that's what PrEP does. That's what a vaccine would do. That's what dealing with all those other stressors and barrier contraception, knowing your risk, managing your risk, that gets us the rest of the way. For me, this is an exciting slide. There's no longer a section for men who have sex with men in the PrEP guidelines. It's just people who have sex. It's the same risks, it's the same language, and it covers all the risk. So we've got commercial sex work, which is new. We've got a history of inconsistent or no condom use with sexual partners, high number of sex partners, a recent bacterial STD, and we have HIV positive sexual partner if that's known. We started out with just the first one. But how many people early in the pandemic of HIV were open about this? Some, not all. That's still true. We know that if someone gets syphilis, I think this will change after the last year, but we knew that someone got syphilis up to 2018, 10% chance in the next year of getting HIV. So we took that information, we added it to the guidelines, and now we can use that to help people get protected. High number of sex partners. I don't know what that means. Anybody want to tell me? I don't know. A sex partner. Inconsistent or condom use. Commercial sex work. This is also something that is a really valuable tool because of the opioid pandemic. So that's created a lot of cottage industry for income or drug access, much of which involves transactional sex. I would hesitate even to say commercial in that, just transactional. The guidelines say commercial or transactional. This really brings, especially women, and we saw that women are getting infected almost at the rate of men in Massachusetts, 40 to 60. Not 90-10, 40 to 60. That's all opioids. That's all opioids. Either from sex with someone who has opioid dependence and has exposure that way, or direct blood-to-blood transmission. We also have an availability for people who inject drug use to start their own PrEP under their own risk factors from being an injection drug user. It also has HIV positive in the partner. Again, that's not reliable. But people who have any sharing of their drug paraphernalia, their injection equipment, works, wires, cottons, any of that stuff, they would qualify for PrEP. Anywhere up to 6 months after the last time they used. So if you got someone who's on buprenorphine, who's managing, someone on methadone, someone on Vivitrol, someone who's shown up to groups because they haven't been abstinent for most of the year, they can still be offered PrEP, they can still take it and still benefit from it should they dib and dab, as it's said. Currently we have two medications that are two flavors of the same medications. I hesitate to use trade names, but I will here. Mainly because they're the only ones out there until recently. So Truvada, tenofovir, emtricitabine has been the mainstay of PrEP since it came out. As soon as that went off brand and we had a generic, promptly the same company puts out a slightly upgraded version for some groups. It hasn't been studied yet for receptive vaginal sex. That's coming. That's important because it is a safer drug. So I'll cast what shade I can on holding that to the last minute until their patent ran out, but it's a great drug. We mentioned PrEP-DAP, Batiste PrEP-DAP. I know our PrEP navigator is here. Jack, if you want to shout out, say raise your hand. I don't know if Greater New Bedford's PrEP navigator is here too, but if they are. Yes. GetYourPrep.com is the US-wide PrEP support tool. This will pay for the entire PrEP treatment for folks that qualify, not labs, not visits, but it'll pay for the medications, which is good because we're talking $1,000 a month. That's available for anybody in the country that qualifies. There's also PrEP-DAP right here in Massachusetts. So some of our Ryan funding goes through this. It's through the Mass DPH. This one's pretty easy. Jack, it's easy? It's pretty easy?
Oh, yeah.
Well, they say they'll get back to you in 2 days or less. I don't know if that's always true.
You gotta know who to talk to.
That's why we have Jack. So these days, we're starting this as soon as we can. We'll get the labs drawn, we'll start the med, get it to the pharmacy, get it covered, and try to get it to them in a week. One of the challenges with PrEP is people don't necessarily stick around. We're dealing with and trying to deal with a group of people that are only tangentially connected to care in many respects. We have some stable folks who have a partner, sure. We also have folks that are young, they're injecting drugs, they don't have a lot of trust with the system. Any opportunity to ever contact is an opportunity for treatment. So future directions for PrEP. This is the fun part. It's not just going to be pills. This was teased by Dr. Naz, which is great. And there's two really cool things, but there's a lot of cool things coming up. We've got injectable PrEP for up to 6 months coming up. We've got enemas. We've got implantables. We've got oral contraceptives with PrEP in it. Pretty exciting. We might even see LARCs with that. The African study on vaginal rings for PrEP was a huge disappointment. It worked, it was safe, but only like 20% of people took the ring. And they just didn't take the ring. So now we've co-marketed it with birth control, putting it together. UMass is on this map, by the way. They're right over here. Hi, UMass. They're developing one. We've also got infrequent prophylactic medications, once a month pill that Merck's developing. And then we have vaginal rings that you can change just every 3 months. So we get some fun stuff coming from the prep world. This is what's coming the most soon, possibly within the year or the next couple of years. Presumably these folks, if they haven't already filed, will be filing by 2024. So we have vaginal rings for 1 to 3 months. We have injectable every 2 months, injectable every 6 months, combined oral contraceptive pills with PrEP pills, once a month pills, and a new daily pill. So we have a bunch of options that are coming up in the next couple of years. I'm excited. Merry Christmas. HIV vaccines have been just a Sisyphean task. HIV sucks. Everybody knows about coronavirus' spike protein. It starts out as a little mushroom, then it sticks into a point to stab itself into your cell. HIV's is more of an umbrella. And if you think about a whole stadium full of people with umbrellas, they all got different colors because HIV likes to change it up every chance it gets. It's got that reverse transcriptase. It's very sloppy, so every copy's different. Anyway, so it's an umbrella that's hiding the good stuff. We want to get to the handle of the umbrella that stays the same for every person. But we're getting close. We've got a few ways that we can do that. There's folks working on T-cell mediated responses. It doesn't give a care about the umbrella at all. It goes after the cell that's been infected. We've got neutralizing antibody response vaccines coming up. This is ones that will completely eradicate a viral load. We're looking to use those for people that are already infected as a therapeutic vaccine. We've got non-neutralizing. These would be preventive. And we have combination responses, stuff that will stimulate both the cellular parts and the antibody parts of the immune system together. The HIV treatment pipeline is coming along nicely too. That slide was too big to even stick up there. But there's a couple of things I want to highlight that we're expecting soon, one of which has already been submitted. Many of the look-alike kind of things, there's a lot of stuff that's going to come out soon. There's going to be 2 drug regimens, so we've got a couple of things on the market now. Cabotegravir, rilpivirine injectables, dolutegravir, lamivudine, got a couple of things that just have 2 medications in them. There's a ton more of those that are going to come out hopefully soon. The long-acting formulation market's also very busy, so we're looking for stuff that's hopefully going to be once every 6 months. The one we have, they're also trialing to do cabotegravir, rilpivirine, hopefully every 3 to 6 months. And that's been a pretty easy medication to use. It's about as powerful as it gets, as safe as the dickens. And the less we can do it, the better. There was a tease earlier too about why injectables can be helpful. I don't like needles. I like putting them into other people. I don't like them in me. But there's a handful of reasons that taking medication isn't always realistic. So you have folks that can't have reliable locations for the medications. I had a guy that brought me his meds that he kept in his car for a year. So homelessness gets in the way of that, or being in and out of shelters. There's the stigma aspect. I have a bottle that's labeled HIV med that's going to out me. There's that issue. There's also just the tearing down effect of being actual with oneself about having HIV every day, first thing in the morning usually. So for those folks, an injectable can really get around those issues. They're not the magical way to maximize adherence that we wish they would be. People still have to show up every 3 to 6 months or whatever, but it gets around those issues. There's also some cool new stuff. Just a couple of years ago, we learned that the HIV capsid doesn't just disappear. It actually carries the HIV RNA all the way into the nucleus, which means it's got a long ways to go. We got a lot of time to attack it. So we have a capsid inhibitor coming out soon. That one's actually been submitted. We have a new take on an old friend. So we have lots of reverse transcriptase inhibitors. Well, I've got this islatravir coming that's a tool effect reverse transcriptase translocation inhibitor. It not only sticks to the reverse transcriptase and binds it up, it actually kinks the viral DNA so it can't reproduce in the future. That looks to be incredibly powerful. They're already doing studies on that in treatment-experienced folks. Old timers with CD4s under 50, getting them up to 100. So that'll be great when we get a hold of that. The maturation inhibitors that are there to break up the ability of the virus to create its new virion particle and get to the next cell. And then fusion inhibitors, we have fusion inhibitors, but we're looking at now, instead of a daily injectable, a weekly injectable, so that'll be more user-friendly. So they can do it for diabetes. So that's what's coming up for HIV treatment and PrEP, a little bit of my thoughts about it. Love to have any questions you guys have, but otherwise I'm going to say thank you, and we'll move on. So thank you guys very much.